Hyperstimulation guideline, the RCOG guideline. Okay, and the first thing which is of noteworthy is that what is the incidence of ovarian hyperstimulated syndrome? What is the reported incidence of ovarian hyperstimulation syndrome? The answer is that clinician must remain alert to the possibility of ovarian hyperstimulation syndrome in all women undergoing fertility treatment, and women should be counseled accordingly. Okay, and it's written that the incidence of ovarian hyperstimulation syndrome is different in different population group. In a cycle of conventional in vitro fertilization, it's written that the mild ovarian hyperstimulation syndrome has been reported to have incidence of 1/3 of the cycle. Okay, in 1/3 of the cycle, there is a risk. While when we talk about moderate ovarian hyperstimulation syndrome, the incidence varies from 3.1 to 8%. Okay, and the question might arise that what is the cause of ovarian hyperstimulation syndrome? The cause is basically due to release of the HCG in ovarian hyperstimulation due to excessive gonadotrophin. There is excessive ovulation induction, so which patients are at highest risk. So the answer is that the woman with the previous history of ovarian hyperstimulation syndrome and the woman with polycystic ovarian syndrome, and whenever there is increased antral follicular count or high level of anti-Mullerian hormone and increased, these are the women who are at increased risk. Okay, so previous history of the PCOS, increased antral follicular count and high level of AMH hormone. These women are at increased risk of the ovarian hyperstimulation syndrome. Now, something about the diagnosis. How would we diagnose the case of the ovarian hyperstimulation syndrome, and what are the differential diagnoses? Okay, about this it's written that clinician needs to be aware of the symptoms and signs of the ovarian hyperstimulation syndrome, as the diagnosis is based upon the clinical criteria. Okay, so we have to assess the patient clinically. And in a woman presenting with a severe abdominal pain or pyrexia, extra care should be taken to rule out other causes of the patient symptoms. And the inpatient clinician experience in the management of ovarian hyperstimulation syndrome should be obtained in such case. Okay, then how would you divide the patient of ovarian hyperstimulation syndrome into different categories? It's written that the time of presentation following trigger injections divide patients into two groups. First of all, early, and second is that of the late. Okay, so early cases of ovarian hyperstimulation syndrome usually presents within 7 days of HCG injection and is usually associated with excessive ovarian response. Okay, and the late ovarian hyperstimulation syndrome typically presents 10 or more days after HCG injection. Okay, after 10 or more days, that is the late presentation, and is usually the result of endogenous HCG derived from the early pregnancy as well. Okay, so these are the two main things which we need to discuss. Now coming to the important table 1, in which the relative history from patients suffering from ovarian hyperstimulation syndrome is written. Okay, so what are the very important history points in a patient with ovarian hyperstimulation syndrome? In that patients, first of all, the time of the onset of the symptoms are very important. Secondly, the medication used for the trigger are important. Number of the follicles, number of the eggs collected, and were the eggs replaced, and how many. Okay, and PCOS diagnosis. Okay, all these things are very important in history. Okay, and what symptoms the patient present? Patient may present with abdominal bloating, abdominal discomfort, nausea and vomiting, breathlessness, reduced urinary output, leg swelling, vulvar swelling, associated comorbidities such as thrombosis. Okay. Another question is that how would you examine a patient with ovarian hyperstimulation syndrome? Okay, the examination in general is by assessment of dehydration, edema, and record the heart rate, respiratory rate, blood pressure, body weight. Abdominal examination is done by checking for ascites, palpable mass, peritonism, and measure the GERD. And the respiratory system is also important because we need to assess for the pleural effusion, pneumonia, and pulmonary edema. Okay, now how would you investigate this patient? What investigation would you carry out for these patients? Important investigations include, first of all, the full blood count, hematocrit, C-reactive protein, urea and electrolyte, because we have to check for hyponatremia and hyperkalemia. The serum osmolarity, because we have to check for hypoosmolarity, and LFTs, coagulation profile, HCG, ultrasound scans. These are very important investigations which we need to do. Okay, what are the other investigations which might be important? Other investigations include arterial blood gases, D-dimer, echo, chest X-ray, computerized tomography, pulmonary angiogram, CTPA, and the VQ scans. These are important. Okay, now how would we assess the severity and reporting adverse outcome? Okay, how can the severity of the ovarian hyperstimulation be classified? Okay, the severity of ovarian hyperstimulation can be graded according to standardized classification scheme. Okay, the four categories are, first of all, the mild, moderate, severe, and critical. The mild include abdominal bloating and mild abdominal weight and ovarian size of less than 8 centimeter cube. Okay, the moderate include when the ovarian size is 8 to 12 centimeter cube, and there is moderate abdominal pain, nausea, vomiting, ultrasound evidence of ascites. So in mild we don't have ascites, in moderate we have ascites. When this ovarian size is less than 8 centimeter cube, it is mild. When it is between 8 to 12 centimeter cube, it is moderate. Okay, so what happened in severe? Okay, and severe we have clinical ascites. Okay, that was in moderate we had ultrasound evidence of ascites, and in the severe we have the clinical ascites. Okay, and patient has oliguria, hematocrit, and so biochemical changes take place. Hematocrit more than 0.45, hyponatremia, mean sodium is less than 135 millimole per liter. Hypoosmolarity means osmolarity is less than 282 milliosmol per kg. Hyperkalemia, potassium is more than 5 millimole per liter. Hyponatremia means serum albumin is less than 35 gram per liter. Ovarian size is usually more than 12 centimeter cube. Okay, now coming toward the critical ovarian hyperstimulation syndrome. In the critical ovarian hyperstimulation syndrome, what we have the tense ascites, large hydrothorax, and hematocrit of more than 0.55, white cell count of more than 25,000 per ml. We have oliguria, thromboembolism, and acute respiratory syndrome. Okay, so when these things happen, it is critical. Okay, so the main point I would like to tell you, in the mild you have to remember the size of the ovary less than 8 centimeter cube. In the moderate you have to remember the size of the ovary is 8 to 12, and in the moderate we have the difference between the moderate and the severe is that in the moderate we have the ultrasound evidence of the ascites, and in severe we have the ascites that can be detected clinically, and in the moderate we also have some biochemical changes as well, and the critical is the one in which we have tense ascites. Since hematocrit is more than 0.55, white cells are more than 25,000. Oliguria, thromboembolism, and acute respiratory distress syndrome means patient is in the critical care unit. So that is a critical ovarian hyperstimulation syndrome. Okay. Now another important thing is that how should we report the patient with ovarian hyperstimulation syndrome? About this, it's written. This is in fact the UK setup. Related to that, it's written that the licensed centers should comply with the Human Fertilization and Embryology Authority regulations in reporting the cases of severe or critical ovarian hyperstimulation syndrome among the patients, and unit that treat the woman with ovarian hyperstimulation syndrome should inform the licensed center where the fertility treatment was carried out to promote the clinical continuity and allow the licensed center to meet its legal obligations. Okay. Now, organization of services. How should the care be delivered to the woman with the risk of ovarian hyperstimulation syndrome? It's very important. It's certain that fertility clinic should provide the verbal and written information concerning ovarian hyperstimulation syndrome to all the women undergoing the fertility treatment, including the 24-hour contact telephone number contact. Okay, and all the acute units where the woman with suspected ovarian hyperstimulation syndrome are likely to present should establish a great protocol for the assessment and management of these women and ensure that they have access to appropriately skilled clinician and experience in the management of this condition. And it's also very important that licensed centers that provide the fertility treatment should ensure the close liaison and coordination with the acute units where their patients may present. Okay. And initial assessment. Okay, whenever the patients come, how should the woman with suspected ovarian hyperstimulation syndrome be assessed initially? Okay, then she comes to you, how can you assess her? Women presenting with a symptom suggestive of ovarian hyperstimulation syndrome should be assessed face to face by clinician. If there is any doubt about the diagnosis of, if there is or if the severity is likely to be greater than mild. Okay, now how would we do outpatient management of ovarian hyperstimulation syndrome? Okay, which patient of ovarian hyperstimulation syndrome are suitable for outpatient care?
Cases with the severe ovarian hyperstimulation syndrome. Okay, so in mild to moderate ovarian hyperstimulation syndrome cases, we can send them home and manage them on outpatient basis. Okay, now another question is that what management is appropriate for in outpatient setting for patients with ovarian hyperstimulation syndrome. About this, it's written that women undergoing outpatient management of ovarian hyperstimulation syndrome should be appropriately counseled and provided with information regarding fluid intake and outpatient monitoring, and in addition they should be provided with the contact detail to access the device. Okay, and SAID should be avoided as they may compromise renal function, and women with severe ovarian hyperstimulation syndrome being managed on an outpatient basis should receive thrombolysis with low molecular weight heparin. Now, the duration of the treatment should be individualized, taking into account the risk factors and whether or not conception occurs. Now, paracentesis of ascitic fluid may be carried out on outpatient basis by ultrasound or transvaginal route under ultrasound guidance, and there is insufficient evidence to support the use of GnRH antagonist or dopamine agonist in treating established ovarian hyperstimulation syndrome. Okay, now how should women with ovarian hyperstimulation syndrome be managed on outpatient basis? How should they be monitored? Okay, and women with ovarian hyperstimulation syndrome who are managed on outpatient basis should be reviewed urgently if they develop signs and symptoms of worsening ovarian hyperstimulation syndrome. Okay, it's very important that in the absence of these review every 2 to 3 days is likely to be adequate, and baseline laboratory investigation should be repeated if the severity of ovarian hyperstimulation syndrome is thought to be worsening, and hematocrit is useful guide to the degree of intravascular volume depletion. Okay, clinician and patient should be vigilant for the signs that severity of ovarian hyperstimulation